Welcome back to World Health SocialGood and Day 3 at the World Health Assembly in Geneva, Switzerland. I'm Christy Feig, the Director of Communications at the World Health Organization, and I'll be your guide as we go through the next hour looking at some of the major issues that are happening here this week. Now, one of the biggest issues coming into the World Health Assembly was the issue of the Ebola response. And you'll remember back in January, our member states came together in a special session to talk about how the organization needed to make some changes in order to be better for future responses like the Ebola response. Because that was such an important issue for the future of the organization, we're going to spend a lot of time talking about it today. And we're going to approach the conversation from several different directions so that you have time to ask the questions you need. Remember, come to us on Twitter at hashtag WHA68 or hashtag SocialGood. Now remember, the Ebola response was of a magnitude we have never seen before. The organization in the past has responded to about 12 Ebola outbreaks in the last 10 years. Anyone who has done an Ebola response will tell you we have never had to build the number of Ebola treatment centers we did for this response, nor of the size. These centers have more beds than we've ever put in an Ebola treatment center before. So that tells you the exponential response that was needed to address what was happening in these 3 countries in West Africa. Now, these extraordinary steps and the extensive work of those communities are really what got us to where we are today, which is in a much better place. Joining me now to talk about the situation today and how the UN worked to support the intensely affected countries and moving forward, where we're going to, is the Secretary General's Special Representative for the Ebola response, Dr. David Nabarro. Thank you so much for joining us, David. Now, David, you've been working in emergency responses for decades. What struck you the most when you took over this response? I believe it was last August.
Yes, it was the beginning of August, Christy, and I must say that the first thing that struck me was the size of the outbreak. I've worked on many different outbreaks in my time in public health, but never anything that was affecting this number of people. Secondly, the severity of the disease. Ebola is such a horrible infection, and when people get it, unfortunately, the time between starting to be ill and succumbing is relatively short unless treatment is put in place. And thirdly, the speed with which the outbreak was increasing. So size, severity and speed. And on the speed, you know that it was doubling in numbers of cases about every 3 weeks. A terrible feeling, because often it takes a week or two to get yourself settled into a role, and then after 3 weeks of working on this, I suddenly realized it's twice as big now as it was when I started. And so, because of these various factors, we had to move ahead with a really complicated response, one that required many different actors to pull together. And that's my fourth and perhaps most important point to you, is complexity like I've never seen before.
Let's talk about some of that complexity. What was it that really drove this outbreak to get to the size that it did before you were brought in?
Well, I think we're doing a lot of work now to understand it, but my quick summary is that the outbreak got into urban communities in July, and it was that spread within Monrovia and Freetown and a little bit less in Conakry, but also some of the smaller towns in the affected countries that really got the thing moving quickly. And that's when we started to see people being very ill in the towns as we were moving around. And secondly, it was also a big traditional approach to sickness and caring that we had to take into account. And so communities actually were needing to look at behavior at its very basic form, how you look after people when they're ill, how you look after people who die, and that added to the complexity and rapidity of spread.
It's something that we're going to get into a little bit later with some of our other guests, the uniqueness of the community and how they did have such a passion of caring for their sick, and what that contributed to the response. It seems today we're in a much different place than we were back when you first started, and it was growing exponentially. Can you just tell our viewers where we are today with this outbreak?
So when the outbreak was at its height, let's say really the end of September, beginning of October, we were seeing nearly 1,000 people getting sick with Ebola each week. That is a huge number. Then at the beginning of January, the number dropped to about 150 per week. And then by February, March, the number was reducing even further towards 50 a week. Now we're bumping a bit from week to week. Some weeks it's less than 10, other weeks like last week it's up nearer 35. But we are really seeing the tapering off, and Liberia has already been declared Ebola free. That was May the 9th, a wonderful day, and now we've got a situation where it's reducing nicely in Sierra Leone, but we've still got some challenges across the border in Guinea, which we're working on very intensively right now to get that country towards zero as well. It'll take a few more months, Christy, but I'm confident that within those months we will see the outbreak come to an end.
You know, I think I've heard you say before that this last stretch is the hardest part.
Absolutely. Yes.
Elaborate on that for me a little
Yes.
bit. What are we doing to get to zero, and why is it so difficult?
So when you're at the most intense phase of an outbreak like this, you're focusing on trying to ensure that you can save people's lives, trying to ensure that if people do die, that their bodies are handled safely and in a dignified way. As you're gradually moving towards the end of an outbreak, you're having to identify each chain of transmission. You're having to know everybody who's been in contact with somebody who's got Ebola. It's like looking for a needle in a haystack in some ways. It's a very tough part of the work because you have to go into communities and work with the people to find those who are ill and to find their contacts and follow them up. It's detective work like nothing else. And perhaps most importantly, you can't miss anybody. It's no good saying we've done 95%, because as Dr. Margaret Chan, the Director General here, often says, it all started from one case, it could end with one case. And it's that absolute need to make sure that we go and cover everybody that really matters at this stage.
I have a question from a Twitter viewer, if I may ask you. Were there any issues with communicating control procedures to communities?
So thank you for that question. And I'd like to say straight away that's right on the mark, because these kinds of disease outbreaks can only be brought under control by the communities, by the people themselves. It can't really be done by the doctors and nurses, can't be done by the outsiders. It's got to come from inside. We often talk about community ownership. And of course, it was the communities owning the outbreak and collectively deciding they were going to change the way in which they do things that transformed the situation in Liberia in October and November last year. It's the community ownership that's transformed the situation in much of Sierra Leone and much of Guinea. But there have been some communities who've said, hang on a minute, we don't really want to change how we treat our sick. We don't really want to change how we handle our dead. Doing it properly matters to us more than taking precautions for our health. It's these communities, sometimes referred to as the reticent communities, who are the ones who we really have to work with carefully. And your viewer is correct in identifying that there are issues, and the most important thing is to tune in to the people, to work with them on the issues that concern them so that they own the response and will be part of the response. And that can only be done through very gradual working and confidence building, and that's what we're doing now.
Okay, one of the things you were just talking about was what it takes to get to zero, the diligence of
Yes.
that last stretch.
Yeah.
But at the same time, in some of these places, as you've said, we've ended the transmission of the virus in
Yes.
many places, and they would be moving more into an early recovery phase.
Yes.
How do you work both angles? How do you help those that have been able to get rid of the transmission in their communities move into an early recovery phase?
Very, very clear. Thank you. And the viewers, this is an outbreak occurring in a part of the world that's almost as big as France. It's a huge area, but it's only a very small part, perhaps equivalent to the size of Normandy, where you actually have the outbreak still going on. But the rest of the place, people are getting on with their lives. Schools are reopening. Health clinics are beginning to start up again. And so what we've got to do there is to ensure that the services restart and recover, but in a safe way, so that they don't inadvertently get caught up again in a resurgence of the outbreak. So helping to get safe basic services going with good infection control, helping to make sure that the schools are open in a good way, helping to make sure that the agriculture systems are working again, the markets are functioning. That's what we're concentrating on right now. We call it early recovery. It's the countries, as always, that are in the lead, local civil society, faith groups and others who are very much out in front, and the international community very much focusing on supporting this early recovery so that as systems get back in place, they will be better than they were before.
It's really that return to normalcy, isn't it, of sorts?
But it's better normal, better than before. I keep saying that because the normal wasn't good enough, unfortunately.
Good. And we're going to talk about that later in the segment as well.
Yeah.
We have another question from one of our viewers, and if you have questions for Dr. David Nabarro, the UN Secretary General Special Representative for the Ebola response, you can send them to us on Twitter. It's hashtag WHA68 and hashtag SocialGood. The next question we have from our viewers, what surveillance measures are now put in place to prevent future outbreaks?
Now, again, right on the button, that question, because it's surveillance that matters more than anything. And there are two approaches to surveillance. One is called passive surveillance, when if there's an episode in the community, the authorities are informed about it and then they respond by coming and helping to identify not just the person who's unwell, but also people with whom that person's been in contact. And then there's active surveillance, when you actually fan out in the community and look to see whether there are people who are ill from village to village, hamlet to hamlet.
Does that take specialists? I'm sorry to interrupt you, but does that take a specialist? This type of surveillance, the active surveillance, community surveillance?
Yeah, it does require specialist skills. Two reasons. One, you don't want to be identifying people who've got other conditions and then setting off false alarms, but at the same time you don't want to miss people. And secondly, you've got to be super sensitive, because communities don't really like people coming and asking lots of questions about what have you been doing and how you're feeling. And so it's got to be done in a really sensitive and well done and carefully done way. And that's why people who've got knowledge and skills are really important. And not only that, they need to have local language as well as an international language, because often communities will only communicate in local language. So the surveillance is happening. I'd just like one last point on that. The local community organizations, neighborhood watch committees, churches, mosques and other groups, they are really, really important in this kind of surveillance. If they're part of the response, if they own the response, then everything's okay. If they're not part of the response, then we get problems.
It's really about getting to the leaders and the influential people in communities.
And having them being comfortable, because if they're not comfortable, if they feel this is alien, this is outsiders coming in, they get very jumpy.
David, I'm going to let you go now. It is always a pleasure to see you. Thank you for the work you do.
Oh, thank you, Christy.
Good luck going forward.
Okay, and best wishes to all the viewers, and hope we can stay working together.
Thank you so much, David. Now, yesterday, remember I told you that all of our Ebola experts were locked away in Committee A because the member states were talking about the changes that needed to be made going forward with the organization. You'll remember that on Monday, I told you that there was a thing called a drafting group. And drafting groups are where the member states go when they still have to work out the final details of a particular item that they're working on. Yesterday, the Ebola work met a drafting group. And so we do not have the news of the outcome of that work for you yet. You'll have to wait just a little bit longer. Rooms are at a premium here for the drafting group, and because everything must be done in 6 languages, the interpreters are stretched thin as well. So they will start their drafting group work tomorrow morning, and hopefully we will have the results of that end of day tomorrow, probably Friday for you. In the meantime, though, we have plenty to talk about. And joining me now is Dr. Margaret Harris. She is from WHO Communications and has spent a fair amount of time in Sierra Leone working on the Ebola response there. And Margaret, I just want to kind of go over some of the issues that the member states are talking about there. First, WHO mounted a major response to Ebola. Tell me about the roles that WHO plays in a response like that on the ground.
In this response, there was an extraordinary range of roles. Normally, WHO plays a coordinating role. This is extremely important, and an advisory role. But in this one, WHO had to play a much wider range of roles than normal, because this was, as everybody now knows, the biggest, an unprecedented and incredibly complex outbreak. So WHO, as I said, coordinated, provided assistance to all the partners who were coming in, helped make sure that the things that needed to be done had to be done, and worked very closely with the governments in order to ensure that all the roles and responsibilities were being met. That took a large volume of our staff. We had to send field coordinators right out into what we call the deep, deep field, way out into the districts, because that's where the virus was often not only transmitting, but transmitting silently. So you really have to be out there and watching. We sent epidemiologists, people who are disease detectives, who really understand, again, not just what the disease is doing, but where it's doing it and why it's doing that. And they send that information back centrally to the people who then look at these things and decide what needs to be done next. Normally we don't do clinical care, but in this outbreak we had to assist with that as well. So we brought in partners who sent in foreign medical teams, and more than 40 more foreign medical teams came to work in the 3 countries. And that made a huge difference. When people knew there was treatment, when they knew that people would provide them with beds, people would provide them with care, people would provide them with the fluids, and people were surviving. We've now got thousands and thousands of survivors. So then people started coming early for treatment, and certainly in Liberia that's one of the factors people think helped that country bring the cases down to 0. And as we now know, Liberia has been declared Ebola free. I could go on, but I think I need to give you a chance.
Yeah, the size of the response sounds quite large for an organization like WHO. Put some numbers to that for me. It's kind of hard to picture what that would look like in the field.
Well, right now it looks like almost 1,000 people in the field across the 3 countries. That's a huge number of people, much bigger than any number of people we've put on the ground. A lot of those people are WHO staff, but they're also people who've come through our networks from GOAN, the Global Outbreak and Alert Response Network, and from all the other kinds of responders who've come and responded to our call for help. It also means supplies, millions of sets of personal protective equipment. And when you see pictures of what that looks like, it's vast numbers of packages in sheds. It's vast amounts of logistics just to get them out there. We've also had people who train in all the hospitals to make sure people use that equipment effectively, keep on using it effectively, and consistently protect themselves.
Now, the member states are asking for some specific changes to the organization. Can you just tick through those for me, just a couple of the ideas, so that we can see what kinds of discussions they're probably having the rest of this week in that drafting group?
So the member states have seen, as this evolved, that there was a need for a really fit-for-purpose emergency response organisation, almost an organisation within an organisation, and that's what they're talking about. Within the WHO is the agency. They've all agreed that needs to protect public health. It's the guardian of public health, and as part of that, WHO needs to respond to health emergencies. So they're saying, right, we need to have people who've got the skills, who have got the flexibility to go out to the countries as and when required. We need to have the funding in place so that's possible. Not so that you have to then go out to the donors and say, please assist us, but you can send those people right away where they're needed. We need to have the set up, the understanding, a proper steering group that can manage this properly. People who are expert in emergencies, who can advise us and make sure that this runs effectively. Now, all those things have already been essentially agreed upon, and they're now just working to fine-tune the details.
Because you're a communications expert as well as a doctor, I'm going to ask you one question that just came in from our Twitter viewers, because I know you can give me an answer in about the 20 seconds we have left, and that is, how will Ebola be prevented in the future?
There are many things. The first thing will be having really strong, resilient health systems that are able to detect the very first signs that this disease and any other disease that's a major threat to human health is out there. Second, that system needs to be able to respond, again, as quickly as possible and stop it.
And in a little bit later in this segment, we will be talking about health systems and what needs to be in place there and how they can be resilient to handle things like this. Margaret, thank you so much for joining us. I appreciate it. So the details that they'll be working out, you heard right there, how we can move quicker, how we can have the right types of people to send in, and how we can fund that early response. But let me go back to the frontline workers here, because really the success that we're seeing on the ground, and remember, Liberia just recently announced that they have been able to end their Ebola outbreak. Much of that is due to the success of the frontline workers. Now remember, there were two groups of people who were at greatest risk for Ebola. They were those who cared for the sick, and they were those who buried the dead. And that's because the way you get Ebola is by coming into contact with body fluids like blood. The sicker the patient, the more virus they have in their blood, the more infectious that they are. These countries have a very deep culture of caring for their sick. It is absolutely inconceivable for them to imagine that somebody in their family, one of their loved ones, could be sick and they would not touch them and care for them. They also have a very important proper burial of loved ones who have died, and many of those rituals involve touching the bodies. This puts people at high risk for Ebola. There were 3 frontline workers that were at high risk. One of them was contact tracers. These are the people who actually go out and try to find the people who have come into contact with an Ebola patient and may themselves be infected. It's important to watch them for 21 days. There's also the teams that did the safe and dignified burials. Remember, a person who has died is the most infectious. And finally, it was health workers, people who were giving the care. So the real success on the ground goes largely in part to these frontline workers who really sometimes paid high prices for caring for the sick in their community. Let's hear what they have to say.
We are doing door-to-door active case search of Ebola patients in Kumala town. We think this is a very efficient way of taking out the sick people from their house. According to the census, there are 8 people inside the house. We'll have to line them all up, see them, physically inspect them. We think this is one of the efficient way to know if somebody is sick. If they are sick, we'll take them to the CCC. I go on all synap. So you see, as you can see, we can see them, we can physically inspect them to know that they are okay, they are well. There are no symptoms of Ebola. So that's why I said this is one of the most efficient way of doing active contact tracing and case search. You can physically see a whole family household, the whole of them. Then you can physically inspect them.
Mobile teams have played a crucial role in tackling West Africa's Ebola outbreak. They have traveled from community to community, seeking out people with Ebola-like symptoms.
Yes, loss of appetite, muscle pain, joint pain, and also headache.
They also have helped trace the people who came in contact with people sick with Ebola, so the state of their health could be monitored. Health workers have been among the people at highest risk of getting infected with Ebola since the beginning of the current outbreak. All possible efforts have been made to train them about their own protection and to provide them with necessary protective equipment.
But we have some of our colleagues in the wards who have been infected and they lost their lives. They were infected because there are no PPE in the wards. They only use gloves and apron, which is not enough protection for them. And now we are here, we are protected because we are putting on full PPEs. And we have people who are monitoring us, how to wear it and how to remove it. And we have enough clothing. They make sure it's well done.
Ebola virus can be easily transmitted from the body of a person who died of the disease and spread among mourners who touch the remains. Hundreds of frontline workers equipped with protective equipment have helped organize safe burials of people who died of Ebola while striving to respect local traditions.
It has changed a lot because at first there was so much misconception that the loved ones they bury them in mass graves and with no respect, with no dignity. But for now, when they came in, they too feel relaxed. They put their mind at ease. They know that where our loved ones are, they are buried in a safe and dignified manner. As you can see around, the cemetery is very clean, and we have people that are working 24 hours a day to see that everything works out well.
Cared for the sick that probably paid the greatest price. It's true that before the outbreak started, there was a shortage of health workers in these countries. That's always the case after conflict. But it really was this group that paid the highest price trying to save their communities. And joining me now to talk about that is Miata Bayan from Liberia's National Ebola Incident Management System. Thank you for joining us. Miata, talk to me. Liberia was just getting a foothold, building back their health workforce after years of conflict when Ebola hit. How strong was that health workforce at the beginning of the outbreak?
So thank you. I should firstly say that significant progress have been made in the availability of the health workforce in Liberia. The density of healthcare workers to the population improved from 2010 to 2015. We also have around 8,000 plus community health volunteers. We have a current public health workforce of about 10,000 plus, and all of that has actually increased. All of that have actually increased over the last few years. But despite the fact that things have improved in terms of the numbers, we still had issues related to distribution of the healthcare workers across our 15 counties. We have issues of attrition of healthcare workers for various reasons we will get into at a later part of the conversation. We also have, most importantly, we did have a strike prior to the Ebola outbreak. So that's why the fact that we increased in the production of healthcare workers, there were still some unresolved issues.
If you have questions for Miata and Dr. Jim Campbell, who is the Executive Director of the Global Health Workforce Alliance and the Director of the Health Workforce Department at WHO, go ahead and send them to us on Twitter at #WHA68 and #SocialGood. Miata, I'm going to stay with you for just a moment. Talk about the impact of the Ebola outbreak on the health workforce.
Well, so first, let me just say, talking about the impact of the Ebola outbreak on healthcare workers, I'm not going to dwell a little bit too much on numbers, because they're actually very valuable people that have died as a result of the Ebola outbreak. So in Liberia, we had a total of 378 healthcare workers that got infected with Ebola. And out of that number, we lost 192. That's almost like 50% of the number that we lost. But most importantly, of those healthcare workers that died, most especially in the most difficult time and the time when we needed them most, were professors at our medical school, were heads of departments. They were trained healthcare workers that a lot of investment had gone into for the last few years. So we lost them. It means we have lost all of the valuable inputs that they would have placed into our healthcare system. But not just them dying, but the implication of their death on the healthcare workers, us, those of us that have remained, have had a huge psychological impact for the fact that we have lost our colleagues. And we who are alive today are no better than those who have died. They stood in the front line, and all of us who have done the same thing. Their families that they have left behind, the children that they have left behind, the impact it has had on service delivery because of their absence, our training institution, the communities that were hardly hit, is beyond the numbers and the number of persons that we've lost.
Liberia is in a very good place now. Congratulations, by the way, on ending your Ebola outbreak. How are you moving forward in trying to get back to rebuilding that health workforce, picking up where you were before the outbreak started?
So let me just say the starting point is that we have to learn from what we've been through. And I think that's the basis for which we are starting to move forward when it comes to our health workforce. As I stated earlier, we had a lot of unfinished business, as I would call it, within the workforce. And looking at all that we have been through, the health workforce is on as a top priority agenda for the government of Liberia. We were working towards a need-based workforce. Health workers that will meet the needs and the demands of the population for essential healthcare services. We are working on issues of production, not just in number, but the right skill set, the right cadre of staff that will provide the services that is needed. We are also looking primarily at the issue of health workers' payment, and specifically in the case of Liberia, allow me to just describe a situation. I mentioned we had strikes, right? Mm-hmm. The issue of payment, we have a good percentage of our health workforce that is not on government payroll. Mm-hmm. And some of those fundamental issues have been the issues that were reflected during the Ebola outbreak. So as a priority for the government of Liberia, we will be working in the next few months to see how those health workers that have stayed in the system for a long time can be rolled onto payroll. That's one. The second thing we will be working on is looking at the issue of regulation, both in terms of production and practice. And you may want to say, why regulation at this time? It's simply because if even you have all the supplies, all of the resources that you provide, we're at the stage where we have to monitor what people do to make sure our healthcare workers stay alive, but also to make sure that we are able to hold people accountable for the setup they need to have to make sure that the environment that healthcare workers work in are safe. We're going to be looking at our training institutions. We do have a health workforce program that we are working on to really also look at strengthening our community-based volunteers and our community-based program. So those are the things. We know it's not going to be easy, but the fact that we have critically talked about it, we will get there.
Jim, let me come to you here now. What Beata is walking us through there cannot be unique to Liberia. Can you talk about how WHO is working with this on across the world?
Indeed. I mean, I think the experience that we've heard there from the words and the wisdom of someone who's had such an experience over the last 12 months and leading very strongly the national leadership response to this should be wholly recognized, and a lot of lessons to learn. And we must remember that it wasn't only West and Central Africa that was tested by Ebola. We had healthcare systems in Europe and in North America that also had to react and look at how they protect their own health workers, the services that they provide. As history will be written, Ebola has tested many outside of Africa. And it is a concern for all. We cannot look to provide the health service, an essential healthcare services package, primary healthcare, universal health coverage, public health, unless we have the strength and depth of a resilient health system with a resilient health workforce. And what WHO is looking to do is to try and maximize the lesson learning from the public health component of this, the infection prevention control, the occupational health and safety, and ensure that we take those lessons around all member states to be better prepared for the future.
Now, if I remember correctly, the member states have asked you and your team to come up with a strategy for human resources for health to present at the next World Health Assembly next year. Why is a strategy like that so important?
Indeed, they did last year. So 12 months ago, they requested the Director General for a global strategy on human resources for health. So it's an exciting period in that respect to also take account of this last 12 months and recognize the crucial role of health workers, and that includes all health workers, as we've seen in West and Central Africa, from the clinician to the laboratory worker to the burial worker, to make sure that we have a new narrative on the complexity of the health workforce everywhere. And the other thing that's important is also it's a global strategy. It's not a strategy for low and middle income countries. It's a recognition that we're in an interdependent world, that we have labor mobility across countries, we have labor mobility within countries, and that we need to be looking at both national, regional, and global solutions to help us underpin the attainment of the Sustainable Development Goals.
Jim, I'm going to let you and Miyata go at this point. I could ask you many more questions, and I'm sure our viewers could too, but I think we're running out of time. But thank you for introducing us really to the concept of what goes into a strong health workforce and the importance of it. And Miyata, good luck as you and your team move forward. Thank you both so much for joining us.
Thank you very much.
All right. Now, every year there is a theme to the World Health Assembly. It is a time when all of the member states will make comments after the Director General's speech. This year, the theme was building resilient health systems. And the strong health workforce that Jim and Miyata were just referring to is a critical part of that resilient health system, but there is much more. And joining me now to discuss that is Dr. Shin-Yu Song, WHO's Regional Director for the Western Pacific region, and Amanda McClellan, who is a Senior Officer for the Emergency Health at the International Federation of Red Cross and Red Crescent Societies. Thank you both for joining us. If you have any questions for them, you can send your questions in by Twitter on hashtag WHA68 and hashtag SocialGood. Dr. Shin, let me start with you.
Thanks.
What is a resilient health system? What does it mean? You're going to have to explain this for our viewers. Thank you.
Yes, the definition of resilient is able to recover quickly from any shock or changes. And while the resilience is good quality in people, it is essential quality for strong health system. Resilient health systems able to adapt quickly in environmental changes such as disaster and epidemics or economic changes. And resilient system not only protect people from illness, it also allows people to access appropriate treatment whenever necessary. Why the resilient systems so important? Let me take an example from newspaper headlines. This shows that importance is. We saw what can happen when the health system is not resilient with the Ebola outbreak in the Western African countries. When these countries were confronted with this outbreak, their systems were so fragile, too fragile to take management on this crisis. And systems could neither detect nor treat Ebola patient properly. And the result was a meltdown. Thank you.
Let me come to Amanda to pick up right on this thought, because this is the perfect thought for a question for you. And if you don't mind, I will go back and forth between the two of you. Amanda, you spent a lot of time on the ground in Sierra Leone, if I remember correctly, working especially with the teams that were doing the safe and dignified burials. He just described basically a meltdown of a system that did not have the components in place to be the safety net. What did you see on the ground in Sierra Leone?
Yeah, I mean, I think there's been a lot of discussion about policies and systems and procedures that we need, and that's all needs to be reinforced. But at the core of that system is people, and I guess that's what we saw in Ebola. It was the nurses and the doctors in the front line that were heavily affected. I think we lost 400 plus in Sierra Leone from a country that can little afford the loss of health worker lives, which will take generations to build back. But, you know, basic systems and basic personnel were missing. The waste management was a major issue. So there was, personal protective equipment and used material still on the grounds of the hospital when I left only 2 months ago. After all the work that had been done, those systems still break down. There's not enough drugs in some of the facilities. There's not enough senior personnel for supervision. So I think while we're here in the WHO talking about strengthening systems and really looking at that structure, we also need to remember what we need to do to support the people that are part of that system.
Dr. Shin, let me come back to you for just a moment. She's now talking about the people that make up this system, and I want to come back to you and talk about what pieces need to be put in place to try to build a health system. What needs to be in place to make a resilient health system?
Well, as we move forward, this universal health coverage, I think developing resilient health system is most important part, and it has to be in highest priority. Many developing countries are limited in their own resources, and they need well-trained health workers and well-equipped facilities. It's especially challenging for these countries to develop a sustainable system over the short time period. Developing health system also very much complicated by the fact that international partners often support efforts based on a specific disease like such as malaria, and tuberculosis, and HIVs, not on overall health system development. This approach often lead to vertical programs that may collapse once support is discontinued. To build resilience, you need a strong primary care system, strong community participation, and simple but reliable referral systems. There are 3 building blocks I would like to mention. First, you must build the public health system on solid foundations with good surveillance and reporting system, and multi-sectoral risk management, and business continuity plan. Second, you must build community capacities so that community participate in and lead the development of the plan according to their needs. And finally, I think you must make system adaptable so that community participate, so that health challenges are changing all the times, so the system must be flexible to meet emerging need and threat. I think as an end, strengthening health system to make them resilient, I firmly believe that it's one of the most cost-effective investment a country can make. Thank you.
Thank you, Dr. Shin. Amanda, that sounds very similar to what it took to get the upper hand on Ebola in Sierra Leone. Talk about that if you would. How would this concept translate on the ground in Sierra Leone?
Yeah, I mean, I think what the doctor mentioned was what we're discussing. Community was at the core of several of the points that he mentioned there, and really the community engagement is what turned Ebola around. We were able to support community action by building the systems around it and really building the trust between the community and the health system, which I think is key. And one of the things we haven't talked about is really accountability of the health system to the community. So, you know, as the Red Cross working as a grassroots organisation, I think it's important we see how we can support the community to engage, but also demand some accountability from the health system. And that's what we saw in Ebola. I think, you know, the safe and dignified burial teams, which, you know, I had a big role to play in terms of supporting, we saw 1,500 people from the community step up and take on a role that no one else would do, which was amazing to see. Very difficult, very dangerous job. And people in the community really stood up and said, if we don't do it, who will do it? And we saw them take on this challenge that really turned the epidemic around. We know that the burials were causing massive caseloads that weren't being addressed by isolation and by case management. And we also know that the community's engagement in changing their own behaviours really turned it around. We would never have been able to isolate everyone. We would never have been able to stop the epidemic without that community engagement. But without the systems, we wouldn't have been able to do it either. So it was the influx of material and you know, being able to reopen. I worked in a small hospital in the very north of Sierra Leone called Kono. And when we arrived, 11 staff had died in 4 days. And they had no protective equipment, but people that were pregnant, ladies that were pregnant couldn't come and give birth. None of the normal services were able to function. And by just putting some basic triage procedures in place, by bringing some basic equipment, by setting systems in place, we were able to not only establish isolation, but reopen the normal hospital for normal services. And I think this is the resilience that we're talking about, being able to manage both the emergency and normal health needs, which is really the core of the meltdown that we saw in Ebola, that people couldn't get treated for malaria. There was nowhere to go to have a baby. And so I think these are the lessons for us moving forward, is really how to build on that community capacity and engage with the community, but also make sure the systems are in place to support them and to have that trust and accountability between the two.
Thank you both for joining us. I'm going to go ahead and let you go, but that really was, I think, the best way to explain the concept and also the translation on the ground. So thank you both very much for your time. I appreciate it. So there you go. The health systems, really the safety net to help keep these countries and countries all over the world in a place where they can handle future shocks, so that in the future we don't get to a point where we have an outbreak of this magnitude. Now, because we are trying to connect all of our digital platforms here, we're asking the head of our social media team at WHO to join us every day. We've also pulled in a journalist from the UN Foundation that's here on a fellowship onto the set every day. It only seemed fair. There were 5 journalists in 5 days. What we're doing is just checking in with them to see what's going on in the media circles and on social media. Sorry, let me start with you. What is the most intriguing project you've been working on in the past day?
Yeah, thanks, Christy. I think it would have to be the Retro World Health Assembly photo project. Every year we're doing this different photo projects during the World Health Assembly. Last year we did people who are supporting the Health Assembly, the year before behind the scenes. So this year we decided to pull the old photos from the early days of World Health Assembly, including the very first one in 1948. So we actually went to the photo library, WHO photo library, and then we tracked down where they were taken here at the Palais, and we matched them up. And it's actually very interesting to see how much different there have been and things that hasn't changed.
I was going to say, what hasn't changed?
Well, we saw like the clothes are different. We're seeing more women, but the building, the rooms are pretty much the same. But it's been fun doing this project.
Well, same place, same building, new clothes, more women.
Pretty much.
We've started an app this year, and we're webcasting live. Given all the different ways that people can connect into the assembly, how popular is the World Health Assembly on social media these days?
Yeah, actually on Twitter it's even more popular than last year. Last year during the peak day we saw about 10,000 tweets. This year on the peak day, which was on Monday, we saw about 15,000 tweets. So we're seeing about 50% increase.
Does that surprise you?
It's actually quite surprising because with the webcast and with the app, I was initially thinking that probably people will maybe tweet less, but in fact, no.
What are they most interested in?
For today, lunchtime, like yesterday, was really popular with the technical briefing and a lot of side events. Those are the 2 popular events today.
Okay. Julia, let me come to you for just a moment. Julia Balluz from Vox. Is this your first World Health Assembly?
Yes, it is.
What do you think?
I think it's fascinating. So I guess you kind of report about these things from the newsroom or from the field, and how decisions are made and how people come together to kind of think about the directions in global governance, and then actually seeing it unfold here and how it works and doesn't work has been really fascinating.
What's the buzz in the media circle?
I guess the big thing this year obviously is Ebola and kind of figuring out how to better prepare for the next pandemic and what kind of reforms need to happen. That's probably been, I think, the thing that's of the most interest.
All right. Thank you both for joining us.
Thank you.
We'll let you go and check in again tomorrow.
Thanks.
Thanks very much. Now, we've spent most of the show talking about, Ebola. So it's only fair that we balance out to something else. So now we're going to take our final segment and we're going to talk about improving the health of women, children, and adolescents. And since 2/3 of this show was on Ebola, I'm now bringing on a panel of 4 to make up for lost time and see if we can balance this a little bit. Let me start with a little bit of background while they're getting settled. Remember, we are furniture movers part-time on this show. Now, 5 years ago, the UN Secretary General launched the Global Strategy for Women and Children's Health, which has been quite successful in driving progress towards the Millennium Development Goals. The result, 2.4 million lives of women and children have been saved. Now, remember a few days ago we were talking about the Millennium Development Goals and the progress that has been made with that over the past 15 years. We're now at 2015 and we're looking for new development goals. But in all, working towards the Millennium Development Goals, amazing statistics. 6.4 million fewer children died in 2013 compared to 1990, and the deaths of women during pregnancy and childbirth have been cut almost in half in that same time. I've got all kinds of faces around me. I've got to figure out who's who. Just bear with me. Now, building on this progress, later this year there's a plan to launch a global strategy for women, children, and adolescents' health. And that is intended to be a roadmap for ending all preventable deaths of women, children, and adolescents by 2030. A very ambitious goal. Joining me now, I know who one of them is. David Liam.
David Liamoya.
Thank you very much. Not gonna be back on the microphone. He's the project manager for the White Ribbon Alliance for Safe Motherhood in Tanzania. Joy Riggs-Perla, the director of Saving Newborn Lives with Save the Children. Joy, thank you. Oh, look, the questions are already coming in. Dr. Marlene Temmerman, the Director of Reproductive Health and Research Department at WHO. Oh, I know Marlene well. Just looking too far, but that means you're Helga. Very good. Helga Fogstad, the Director of Global Health Education and Research at the Norwegian Agency for the Development Cooperation. We've got quite a big panel, but that means we get a lot of perspective here. Marlene, I'm going to start with you because I know you need to leave early. Later this year, there is a plan to launch a global strategy for women, children's, and adolescents' health. You were deeply involved in this, if I remember correctly. What does it aim to achieve?
Christy, thanks for the question. And as you said, the previous strategy was for every woman, every child, because in 2010, the Secretary General said, well, MDG 4 and 5 are lagging behind, so we needed an extra effort, we need a global strategy. And you have shown already the figures and the results. I'm not going to repeat this. Now for the future, it was clear that the young generation is actually not really covered in the current Every Woman, Every Child strategy. There are, of course, a lot of data on adolescents, on young girls, young boys, but more needs to be done for this huge dividend of young people. That's why, at the request of many, in the UN, outside stakeholders, it was decided to give more focus on the young people and adolescents because they are the future. So now, as far as the process is concerned, the difference with the previous strategy, I think, and the previous MDGs was that it was more conceived by a smaller group of UN and a smaller group of people, and now it's really a very broad consultation. So what does it mean? That the new global strategy, it's called Every Woman, Every Child, Every Adolescent, in every setting, taking into account humanitarian settings, looking at inequities, inequalities. And that the process is much more consultative. So it's countries, governments, but also the civil society, the young people themselves, they can give input. And we have developed this consultative process. There has been a consultation in New Delhi, last month in Joburg, and there is an open process on the internet. So people who want to contribute, we have kind of background papers on the woman, the child, the adolescent, on health systems, innovations, on social determinants, and many more. And everyone can contribute to that process. It's still open till the 5th of June, so please go to the website, read it, and give us your input. And then the last thing I want to say is that in the global strategy, Every Woman, Every Child, one of the priorities was survive, reducing maternal mortality, reducing child mortality, which is great, and we still have a large unfinished agenda that we don't stop the MDGs, of course. But now there is more on survive and thrive. Adolescence, it's also about health and well-being and how can we do it differently. So how can we transform and involve young people more in this process about adolescence?
You know, you touched on something just a moment ago. I wanted to ask a quick follow-up question before I let you slip out. We often see the women and children together, and adolescents a little separate. Now they're all together. What's the benefit of that?
Well, I think we have to look at women not only as mothers, because in the previous efforts it was like a woman as a pregnant woman in her task of bearing children. Right now there is much more emphasis into women's health, not only the child, the pregnant woman, but the woman, the NCDs, the cancer, all the women's issues are there, violence against women, so many more women-related issues. There is, of course, the pregnant woman and the child that goes together. And just to say, if we invest more on delivery, childbirth, we really can have a triple return on investment. We can save women's lives, neonates, and prevent stillbirths. But then adolescents are a separate group. They are young girls, they will be mothers, but they will be women in their own right. And every woman, every child, every adolescent is also looking at older women, because life doesn't stop at 49. Most of our statistics are from 15 to 49, so women of reproductive age. But this new framework is also looking at women and their needs and their health, not only mortality, but also their health and well-being beyond 49.
Thank goodness life doesn't stop at 49.
We all agree on that, I think. Couldn't agree more, Christy.
Before I let you slip away, if people want to participate in the consultation before June 5th, where do they go?
They go to the website of PNMCH, the Partnership for Maternal and Newborn Child Health, and there they can find all the documents. It's also at the UN Secretary General's website, so there are several entry points where you can find every woman, every child. If you look for that, you will find it.
Terrific. Thank you for coming by, and you can slip out as you need
Pleasure.
to. Joy, let me come to you next. Your organization recently released the 16th annual State of the World's Mothers Report. What did this report tell us?
Well, as a matter of fact, I brought a copy of the report with me so people can see the cover. This is a report that Save the Children issues every year, which has an index for the health of women and children and ranks countries as the best places to be a mother and the most difficult places to be a mother. So as expected this year, the Scandinavian countries came out on top, so it was Sweden, Norway, Finland, those countries were at the top, and also, not surprisingly, the countries that have been suffering a lot of conflict in Africa are at the bottom, with Somalia actually being at the very bottom, but other countries like the Democratic Republic of Congo and Niger, those countries are very much at the bottom. In addition to that, though, the report reviews some of the good news that we've heard about earlier in terms of reductions in maternal and neonatal and child health. And it's entitled The Urban Disadvantage, and the reason for that is because I think for the first time it really calls attention to the inequities in healthcare that exist in urban settings between the very rich and the very poor in urban settings. So it goes through an analysis of about 40 countries by wealth quintile and shows that the disparities among the health status of women and children in major cities in the world are actually widening, and about half the countries have very severe gaps between the rich and the poor for maternal and child health.
Before I get you to elaborate on that, I want to tell my viewers here that if they want to ask questions of this panel, hashtag WHA68 and hashtag SocialGood. Joy, let me come back to you for one question on that. Why is the world struggling so much to close that gap?
Well, I think in the past we have been operating off the assumption that most of the neediest people in the world live in rural areas. I've been working in public health for the last 30 years, and we've always talked about community health workers and community structures and organized our programs assuming rural residents. And I think that now more than half of the world's population lives in urban areas, and we've really got to have a paradigm shift in the way we think about urban populations and be much more deliberate about targeting the urban poor, those that are living in slums, and think about providing not just narrow health services, but a broad array of services, social services that will help uplift them all together, entire families.
All right, State of the World's Mothers Report from Save the Children. Thank you, Joy. David, over to you here for a moment. Tell me a little bit about your grassroots work in Tanzania to improve maternal health.
Okay, thank you very much. We've been doing a lot of work at the grassroots level, especially with the citizen. For example, in Rukwa, Tanzania, where we did an assessment looking at the availability of CMOC services, because this is the promise which made it by the government in 2008. By 2015, at least half of the health centers providing CMOC services. These are life-saving care services, comprehensive. So we did an assessment looking at how the government have made the progress toward that commitment. And we came to realize that actually none of the health centers in one region providing that kind of services. So we actually involved citizens in that process. And that was 2013, 2 years ago. Using the existing resources, using existing structure, we were able to make a turnaround. By this year, actually even half of the health centers providing CMOC. And the secret is one. We actually made the citizen being the center of everything, because at the beginning or before, citizens were not involved in setting their priorities. Citizens were not involved in making the budget for themselves. So it was basically planning based not on evidence. So you're able to demonstrate that, okay, these are the needs of the citizen, and you guys, you need to sit together, because the practice most of the time when we hear about citizen and the government, it's a clash. But you're able to harmonize that situation, making sure that, okay, you guys, you need to work together, and citizen, these are the end users. They've been a buzzword this week that there's nothing for us. Nothing about us without us. So it was basically trying to demonstrate that, okay, if you're planning for citizens, let them plan, let them set priorities based on what they want, and we're able to achieve sustainable, very substantial results.
Very much what Marlene was speaking to as well, wasn't it? Let me jump to Helga, and then you guys have questions coming in from Twitter, okay? Helga, let me come to you for just a second. Where have we made encouraging progress on improving children and maternal health? What do you see?
We've made progress in many countries. I mean, we've reduced child mortality by 45% and also maternal mortality by 45%, and the other one was 49%. So we have really done a lot of differences, but we have a lot left. There is an unfinished agenda. We need to do more. We need to concentrate also on the equity problem. We have to reach the unreachable. We have to focus more on that. So, but there is issues of better health, better education. A lot of success has been done, and a lot of reasons for that, Christy, have been the mobilization between partners. The UN Secretary General has been absolutely great in spearheading the global strategy. The multilateral organizations, WHO, UNFPA, UNICEF, and they're really coming together in having increased the mobilization of that has been needed to make success.
Elaborate just for a second for me. How do we address the equity issue?
Well, we have to reach the unreachable. It's both as in Save the Children were saying that it's also an urban poor, but also in the rural areas. We have to pay better attention to where we have the pockets of unfinished agenda lie, and pay better attention to that. And I think, given that we've done so much progress, that there is time actually to do that now.
Terrific. First question coming in from our viewers. What is the biggest issue facing women and children's health? Joy, you want to take that one?
Well, I would say that it really is, going forward, the unfinished agenda. It's the fact that you've heard the figures, we have encouraging progress, but we still have a lot of work to do. And I think that what we have going forward to finish the agenda on both the health of mothers and children will be much more difficult, because we have to deal with more than just disease issues. We have to look to social factors like social exclusion that prevent women and their babies from coming to clinics or being treated properly. So it is going to be a much more difficult, maybe more costly and more targeted effort to make progress.
Okay, everybody behind the camera is giving me a rap sign, even though I still want to talk to David about how we track progress and things like this, but I can't, or they're just going to start throwing things at me. So I will say goodbye to all of you. Really, we could continue this conversation easily for another 30 minutes, and I won't ask you the white card, which was what keeps you up at night. But really, lots of interest in this topic from our viewers, so thank you all for what you do. That's all we have time for today. Really a busy day here at the World Health Assembly. Committee A has been underway. We've made lots of progress. We have a malaria strategy that has made it through Committee A. We have a program budget that has made it through Committee A. And the Ebola work will be breaking into a drafting group, so tomorrow we should have loads of information for you. For now, that's it from WHO and the World Health Assembly here in Geneva. I'm Christy Feig.